In a country burdened with disease, thousands of South Africans are diagnosed with life-threatening illness every year. Most of them will experience severe pain and won't have access to cheap and effective pain medication. For those who die, many will do so without the basic human right of dying with dignity and without suffering. Palliative care is an approach to medicine that aims to change this. It goes against our very nature for a parent to have to deal with the death of their own child. 2 years ago, Clement's parents believed they were going to have to face this unimaginable ordeal. Born with cerebral palsy and epilepsy, his condition is completely debilitating. He's unable to feed or care for himself and has difficulty breathing and swallowing.
Clement wazalwa ehlala ngokugula. Lokho azalwa ehlala ngokugula. Ehlala ngokuya kodokotela njalo kodokotela kodwa engasini ehlala eneyinhlungu.
Born to poor parents living in a rural township on the outskirts of Verulam in KwaZulu-Natal, receiving the medical care that Clement needs has been a constant uphill battle. When his condition deteriorated, they were told to prepare for the worst.
Hayi ngangikhala ngase ngizacinga ingaka me comes stink ngoba manje kwathiwa nje segula kakhulu kufanele ngisayine sekuphelile ngaye hayi bangiduduza odokotela hayi bangiduduza no sister basethi ngaphatheka kabuhlungu uzoba ngcono umntwana is die wesenhlungu yini esefile sikwena.
Dr. Julia Ambler, one of a handful of pediatric palliative care doctors in the country, was called in.
We were asked to see Clement because he was literally at the end. The doctors who had been treating him for 4 months in hospital didn't know what to do. So his condition was very, very poor. He was grossly underweight. He was having seizures, infections, permanently on the oxygen. They just couldn't get him off. So he was in a pretty dire state. And when we met the parents, that's what we spoke about. We said, look, we don't know where we're going. I think the end is coming.
Last year, 15,000 South Africans were diagnosed with drug-resistant TB. Difficult to treat, it can leave patients unable to care for themselves for months. These palliative care nurses not only administer TB medication, but also bath and feed their patients. Palliative care is an approach to medicine which aims to improve the quality of life for a patient by doing whatever one can to make them more comfortable and relieve their suffering. It's most often associated with hospice and patients who are on their deathbed.
I think it's something that developed out of oncology care in the early 60s and 70s when hospice care was first established. Hospice care was provided to people when the oncologist felt that they couldn't treat any further, and they would say to the patient, there's nothing more that I can do. And that's one phrase that should be eliminated from a doctor's vocabulary, because there is always something we can do for a patient. But the patient felt abandoned. The doctor felt that they'd failed the patient, and in referring to hospice, hospice got the reputation of being a place that you went to die.
Palliative care can be applied to patients with HIV, TB, cancers, and other serious illnesses.
And palliative care is applicable from the time of diagnosis of a life-threatening or life-limiting illness in order to support the patient and the family through the difficulties that are associated with serious illness. So the physical problems, including pain, which is a big issue in palliative care, and the emotional problems and the spiritual problems also.
Sadly, this care is almost non-existent in both the public and private health sectors and is provided almost exclusively by NGOs in South Africa. It takes more than just medicine to recover from illness. Abraham is HIV positive and has TB. He has no living family to care for him. His disease could quite easily be a death sentence.
You need to take food before you take these tablets so that it can work properly in your body, because if you don't take meals, it won't work properly. And you can vomit even the treatment just because the stomach is empty. But if you are having something in the stomach, yes, it's okay. So that's why I'm preparing Abraham this food before he take the tablets. Because we find him in a critically ill condition, but now there is a difference. Well, yeah, we can see a smile of Abraham now.
Sadly, not all of her patients will recover as Abraham has. More than 250,000 South Africans died of AIDS-related illnesses last year.
Even if you are going to die, you have to die with dignity. You have to die clean. You have to die free from pains. You have to die with next to somebody that's giving you a support.
Treating symptoms, particularly pain, is a big part of palliative care.
Without palliative care, people who have serious illnesses suffer, and that's the issue, and why palliative care is seen as the relief, or the essence of palliative care is the relief of suffering, because who manages their pain? Unfortunately, our doctors and nurses are not well trained in pain management because they're trained in disease management.
Busisiwe has stage 3 cervical cancer. It was discovered late and has spread to other parts of her body. Nothing more can be done to save her. Her daughter gives her morphine every few hours to try and ease her unbearable pain. Morphine is a safe, cheap and effective painkiller. However, for people like Busisiwe who live in remote areas, it can be very difficult to get. Legislation dictates that only a doctor can prescribe it, and the script is only valid for one issue. This leaves thousands of South Africans stuck using over-the-counter medication to battle excruciating pain.
It's really essential, especially for people who are in rural areas, who have limited access to doctors, but who also are too sick to come from their home to the doctor or to the hospital. And will they die during transit? Will they then die at hospital instead of at home? Whereas the nurse going to them at home could provide them with good pain management.
Hospice are campaigning to have this legislation changed to allow for trained nurses to prescribe the drug. 8 women in South Africa succumb to cervical cancer every single day. Most, if not all, will die in pain.
Ngoba iy'nhlungu zinzima, zinzima iy'nhlungu. Angilali ebusuku, ubusuku nemini. Nasemphinjeni akasehle namaphilisi. Mangithi ngiyaphuza nje, senginamalonda wonke umphimbo. Bengicela usizo. Ney'mbi lapha ezingivelayo zibuhlungu. Kabuhlungu iqolo.
Sick children are at the mercy of the adults and doctors around them. As a result, the care children need for their pain and symptoms is often overlooked.
I think that if there's limited access for adults to palliative care, it's even more so for children, for a couple of reasons. It goes against our kind of very being to think of children having short lives. The other thing is, if you consider how a child seeks health care or receives health care, they have to do it through an adult. It's also part of that same concept that we don't feel the child's pain. How do we measure a child's pain? But that's another reason why children seeking care, it may be delayed.
Clement has difficulty swallowing, so his mother pumps saliva out of his mouth every few hours to stop him from inhaling it into his lungs. He's been out of hospital 2 years now and is doing well, something Dr. Ambler wouldn't have believed possible when she met him.
What we found was a child who was in pain, who was having lots and lots of muscle spasms. When you've got cerebral palsy, it's quite a common symptom that the muscles get very, very spastic and painful. And so we started with pain management. And very quickly after that, so his condition started to improve. And they were then able to wean the antibiotics off and improve his seizure management, and everything snowballed from there until they had a child who was well enough to go home.
For the 4 months that Clement had been in hospital, doctors had been focused on treating his recurring lung infection. His condition deteriorated, but at no point had anyone tried to assess or address his pain.
Doctors don't focus on pain at all. When you learn as a medical student, and nurses as well, you're very disease focused. So I'm going to worry about the fact that you've got TB or HIV or appendicitis. I'm not thinking about the pain that might go along with that. And I think it needs a mindset change. People actually need to be able to assess a child holistically, and an adult for that matter, where they are, what are they experiencing.
Pain assessment can be difficult, especially for children.
That if you've got hypertension, you check the blood pressure. If you've got a fever, you check the temperature. You can't measure pain. Measurement of pain is what the patient says hurts and how severe is the pain. But because I don't experience the pain, I don't know how bad it is. So it's a poor assessment that is the first thing, and how do we assess pain? So in palliative care, we teach people how to do that pain assessment.
Despite morphine being on the list of essential drugs that all hospitals have to stock, healthcare workers are often afraid to use it.
So I think from a medical student point of view, this is where it starts, this fear that it's going to suppress breathing, that we're going to stop someone from breathing if we give morphine. And if that's the feeling in adults, you can imagine how much more that is when it comes to children. Everyone goes, oh, morphine, how can you give morphine? People tend to think of morphine in hospices where elderly grannies are dying with cancers and that sort of thing. And it's really only reserved for the very terminal phases. But actually, it's an excellent painkiller, and used appropriately, which we've done. You can see that after 2 years, he's still on it, and it hasn't done anything, it hasn't changed anything, and he's certainly not pre-terminal at this stage.
Less than 5% of children in South Africa who need palliative care have access to it. For many, their pain and suffering will go unnoticed and untreated. Consistent pain can have a huge impact on recovery.
The other thing is when a child is fighting pain all the time, it's very difficult for them to grow or to put energy into anything else. So for Clement, now that his pain is well controlled, he's actually managed to use anything that he's taking in to grow and become a much bigger, stronger boy. Whereas when we first met him, he was grossly underweight.
Hello, there's my smile. Where's my smile? How are you, Clement?
So by managing his pain, we managed to improve his breathing, improve his chest, reduce his pneumonias, but at the same time he's also had energy left over to, instead of fight the pain all the time, he's managed to grow and develop. And you can see that he smiles and he's interactive in his own environment.
However, Clement accessing palliative care is the exception. 200 children under the age of 5 die in South Africa every day.
I think the idea around palliative care is that every child should reach their full potential, regardless of what their diagnosis is and regardless of how much time they've got left. So whether a child is going to survive for a day or many, many years, as in Clement's case, it should be all about the quality of the time that they are around.
At the top of this mountain lies Mkhuze, a rural town in northern KwaZulu-Natal. One might assume that in a place so remote, with only one hospital and a handful of clinics, there would be no access to palliative care. Despite being written into many Department of Health strategies, the reality is that palliative care is not implemented in most of our health facilities.
So currently within the public health sector and also within private healthcare, there is not good access to palliative care. The access to palliative care comes when a person is fortunate enough to have been referred to a hospice. And that is what we're trying to change. We're trying to make sure that all doctors and nurses in the country are trained in palliative care and that all health facilities provide an option of palliative care.
The population of Mkuze are luckier than most thanks to Dr. Pule, who has started a palliative care protocol at Bethesda Hospital.
When my mother was still alive, she had diabetes and also cardiac failure. As a result, her quality of life was so terrible in the past 10 years before she actually died, because she had so many hospital readmissions. Her pain was just not properly controlled. And I realized, you know what, there's so much as health professionals we can actually do as to improving the quality of life of patients that we see. It's not enough for me to just write a script and say, well, now, fine, there's your antibiotic, goodbye. Pain control is very important. Explaining to the patient what they have is also very important.
This patient was one of the first to benefit from Dr. Pule's program. She has Kaposi sarcoma, a cancer related to HIV infection. Kaposi sarcoma patients usually have painful lesions and ulcers on their body. The lesions on her feet were so severe that she was unable to walk.
This leg was swollen and it was smelling. When she actually came through, she was always in absolute agony. She was in pain from the ulcers that she had on the feet. So morphine was introduced very early when she came through. I mean, now when you ask her about pain, she's actually very comfortable. She's able to stand without feeling much pain.
It's important for palliative care to exist in our hospitals so that it can be applied as soon as a patient is diagnosed.
It's been shown that the earlier the palliative care is instituted, it improves the quality of life of patients. And thus, as a consequence, as I said, patients have a positive outlook on life, they tend to live longer. And when patients are constantly in pain, they become depressed. Then as a result, depression impinges on their clinical outcome at the end of it all.
This has been the case for his patient.
Her quality of life is improved. She's now able to move. I mean, patients who are always lying in bed, they can't move, they just become depressed. But now she's able to wash her face, she's much more happier. So, I mean, her outlook is actually quite positive, and we're seeing that as a result, she's actually beginning to improve.
Bengihlala nginovalo ngisaba ngitshela ukuthi hayi impilo yami vele ayisekho iphelile. Kodwa hayi manje sengiyayitshela nami sengiyayifanisa nabanye abantu abaphilayo ngoba nami sengibona ngingcono kakhulu le ndlela engangiyiyona. Hayi ngiyayibongela ukuza kwami la ngoba kuba ngizanga la ngabe mhlawumbe angisekho emhlabeni. Ngoba ngihambile ezinye izibhedlela kodwa usizo ngilutholanga. Kwakungami babe ngibuyisa nje nginjalo kodwa nje ngeza la hayi sengibona ngingcono kakhulu.
Palliative care calls not just for the treatment of the illness itself, but also any other symptoms which may arise as a result.
She's been getting chemotherapy with us, but most important, she's been seen by the other multidisciplinary team members. So she's been getting physio, she's been getting occupational therapies, and she had been seen by the psychologist and the social worker.
This has all happened at an under-resourced rural hospital. Dr. Pule believes the principles can be applied anywhere.
Even in an urban setting, palliative care is still sort of not practiced up to par, even though you still do have psychologists, physiotherapists readily available. So it's not an issue of the human resource shortage, but it's an issue of starting the program itself, then feeding people into that particular program. At the moment, we don't have the palliative care program in place in a hospital setting. So what you find is you find a physio and OT working separately in their separate entities. So I think palliative care brings them all together in one place and say, okay, let's take care of Mr. Lamin.
Sadly, for many, especially in more rural areas, diagnosis and treatment of serious illness can come too late. Dr. Pule has received a new patient with advanced breast cancer.
She is a 65-year-old lady coming in with a history of a right-sided tumor on the breast, and it had been there for the past 2 months. And the only reason why she came through with this tumor is because it started bleeding for about a week before she came to hospital, and it started being painful. And ever since then, she had been going to the local traditional healer and getting some traditional medication over there.
1 in every 29 women in South Africa will develop breast cancer. If caught early, it can be treated. Most, however, like this patient, only catch it once it has spread.
The most important thing, pain medication is very important in this particular instance. So making sure that she is pain-free, because now that tumor is fungating and it's painful. We're going to be administering morphine. My preferred method now will be to give it subcut, because it is less painful to the patient.
Her care doesn't end there. Communication with patients and families is an essential part of palliative care.
It's a holistic care, so physical pain management is very important. Now we need to get the social worker involved and the psychologist to now for us to come explain properly in words that the patient will be able to understand what exactly she does have.
Cancer cases are expected to double over the next 20 years, making palliative care more and more essential.
The need is enormous. There are just so many unwell people out there who are not getting access to proper pain medication, to proper counselling, to proper bereavement care after they've lost a loved one. And we really need to be trying to find a way to offer that. I think the bottom line is that the vast majority of South African adults and children have very little or no access to good palliative care. So that's where we need to start. But I think looking at that, you've got to go back to our education systems, and we need to look at how we're training our young doctors to be practitioners, focusing on those other aspects of quality of life, that it's not about death and dying, that it's actually about living, but living well.